شكرا جزيلا. Thanks to all President and all guest speakers. And lovely Ismailia. Thanks for Dr. Hatem for inviting me. Our talk today is the diabetes mellitus, the ophthalmic story. I have no financial interest in anything that I am presenting. Diabetes is a global epidemic affecting millions of people all over the world. Adults with type 2 diabetes make up 90% of all patients with diabetes. Type 2 diabetes mellitus prevalence is increasing. These are the main systemic complications of diabetes. A team approach in managing the diabetic patient is mandatory. Regarding the ophthalmic consequences of diabetes, the main diabetic complications in ophthalmology are the retinopathy, the macular edema, the cataract, and glaucoma. These are the relative frequencies of these complications. Diabetes mellitus is the leading cause of preventable blindness in the adult working population. Screening for diabetic retinopathy is essential to detect referable cases that need timely full ophthalmic examination and treatment. Resources for nationwide screening programs are scarce in many countries. New technologies such as scanning confocal ophthalmoscopy with ultra-wide field imaging, handheld mobile devices, teleophthalmology, and artificial intelligence help promise. Plus, screening for diabetic retinopathy also has the added benefit to identify people at risk of other diabetes-related complications such as neuropathy, nephropathy, cardiovascular disease, stroke, and peripheral vascular disorders. The hope is to prevent this. The mechanism of diabetic retinopathy is microangiopathy. It's a combination of microvascular occlusion as well as leakage. The main risk factors are listed here. The duration is very important. Also, glycemic control is very important. I will not repeat what Dr. Mayeda told before. Blood pressure or hypertension is a very important risk factor. Obesity. Obesity is strongly related to insulin resistance. Pregnancy. Pregnancy is associated with rapid progression of diabetic retinopathy. In addition, rapid implementation of intensive glycemic management in the setting of retinopathy may be associated with early worsening of retinopathy. Smoking is also associated. Hyperlipidemia is also associated. Kidney disorders or decreased glomerular filtration rate was independently associated with increased diabetic retinopathy. The greatest association was with type 1 diabetes mellitus. Genetic predisposition. A summary. Current management of diabetic retinopathy. The alarming symptoms to seek ophthalmic care. Gradually worsening vision or sudden visual loss. Eye floaters, blurred vision, ocular pain, ocular redness, diminished night vision. Many classifications exist for diabetic retinopathy. One of them, and the most well-known all over the world, is the International Classification of Diabetic Retinopathy. Also, diabetic macular edema may be classified clinically or by OCT. These are the main lesions we find in ophthalmology. This is the retinal microaneurysms arising from the venous end of the retinal capillaries. This is histological preparation. This is what is seen on color fundus photography. The dot and the plot retinal hemorrhages, and this is their appearance on fluorescein angiography, appear as black dots of blocked fluorescence. Hard retinal exudates, cotton wool spots, venous bleeding, venous looping, and intraretinal microvascular abnormalities. In the proliferative stage, new vessels appear, neovascularization of the optic nerve head, neovascularization elsewhere in any part of the retina. The pointer, the laser there? Okay, okay. Neovascularization elsewhere. Neovascularization of the iris. Vitreous hemorrhage, pre-retinal hemorrhage, diabetic tractional retinal detachment. The main investigations we do in ophthalmology is fundus fluorescein angiography. It's an old technique, but still very beneficial to study the retinal as well as the choroidal circulation. Optical coherence tomography. It is a non-invasive diagnostic technique that renders an in vivo cross-sectional view of the retina. It is very sensitive to within at least 10 to 15 microns. This is the theory of the machine. This is the appearance of the normal macula through OCT. It appears like what is seen in histological preparation. We can see the 10 layers of the retina, and we can assess every layer separately. This is an example of cystoid macular edema as a complication of diabetic retinopathy on OCT. Another machine, the third one and the last one, is the OCT angiography. This is the future, and this is a revolution of retinal imaging. It is a non-invasive technique for imaging the microvasculature of the retina and the choroid. Uses laser light reflectance of the surfaces of moving red blood cells to accurately depict vessels through different segmented areas of the eye, thus eliminating the need for intravascular dyes, no dye injection at all. This is the appearance on OCT angiography. Regarding the ophthalmology management, in addition to medical management, as mentioned in the previous lecture, this is very important for us. The specific ophthalmic measures, first of them is the laser therapy. The laser therapy we use in ophthalmology for diabetic retinopathy may be in the form we call pan-retinal or scatter retinal photocoagulation, or the focal form. The pan-retinal or scatter laser, all these white spots are scattered all over the retina, sparing the posterior pole, sparing the optic disc, sparing the major retinal blood vessels. It is indicated in severe non-proliferative diabetic retinopathy and also in the proliferative form. This is evidenced by the diabetic retinopathy study and the early treatment diabetic retinopathy study. Early treatment diabetic retinopathy study proved that early PRP treatment decreased the risk of high-risk proliferative diabetic retinopathy by 50% as compared with the deferral group. Macular laser treatment has been the mainstay treatment of clinically significant diabetic macular edema since the publication of the early treatment diabetic retinopathy study. The second main line, we use intravitreal injections about 14 years ago for the treatment of diabetic retinopathy. The main materials used, first of them is the anti-vascular endothelial growth factor agents. These are the main component of the main materials used in the market. Intravitreally injected antivascular endothelial growth factor are widely administered for the treatment of diabetic macular edema as well as proliferative diabetic retinopathy. The second, the intravitreal steroid injection for macular edema. These are the commercially available steroids used for intravitreal injection. The third line is the vitreoretinal surgery or vitrectomy. We remove the vitreous blood, the preretinal blood, remove any epiretinal membrane, reattach to the retina, and may apply laser photocoagulation in the form of panretinal photocoagulation. These are the main indications of vitrectomy in the diabetics: non-clearing vitreous hemorrhage, traction retinal detachment involving or threatening the macula, combined traction or rheumatogenic retinal detachment, macular edema associated with posterior hyaloidal traction. This example of the main indications of diabetic vitrectomy in ophthalmology. Regarding the screening we need in ophthalmology, the International Council of Ophthalmology provide a framework for developing regionally applicable diabetic retinopathy screening guidelines. First, we should specify a specific classification of diabetic retinopathy. Second, we should address the systemic factors and address the target parameters associated with diabetic retinopathy. Third, screening and referral: why, who, how, and what. Why we screen for diabetic retinopathy? We all know that the vast majority of patients who develop diabetic retinopathy have no symptoms until the late stages with diabetic macular edema or traction retinal detachment. Also, the efficiency of laser photocoagulation or antivascular growth factor inhibitors in preventing visual loss from this complication is well established. However, these therapies are more beneficial in preventing visual loss rather than diminished visual acuity. Also, screening has the advantage of identifying other diabetic-related complications such as neuropathy, nephropathy, and the cardiovascular disorders. Plus, the financial impact of treatment and the financial impact of diminished vision. Who will do the screening? In the past, most countries have relied on ophthalmologists and physicians to screen all people with diabetes. Nowadays, with the shift from ophthalmoscopy to digital retinal photography, technically trained and certified screeners and optometrists have come into play. This is the reliability of screening by optometrists all over the world. The concern is that in some countries, optometrists are not eligible to dilate the pupil, only ophthalmologists. This has been overcome by the invention of non-mydriatic retinal cameras. In some cases, we use cameras that does not need mydriasis, like this. These are the main differences between ophthalmologists and optometrists, who does not know. When to do screening, the same like Dr. Mayada said, people with type 2 diabetes mellitus are screened first at the time of diagnosis, and the people with type 1 are screened first at puberty or 5 years after the diagnosis. The follow-up depends on the disease severity at time of diagnosis. It could vary from 1 to 2 years when there is no retinopathy to have yearly review for cases with established retinopathy. Also, women with pre-existing type 1 or type 2 diabetes who are planning a pregnancy should be told about the risk of developing or progression of diabetic retinopathy. It's very important for ophthalmologists to know that antivascular endothelial growth factors are contraindicated during pregnancy for fear of affecting the vasculature of the developing fetus. These are the main strategies for screening all over the world. How to do screening? I need only 3 minutes. The International Council of Ophthalmology has specified a special program. First, proper history taking, history of the drugs and the timing, proper visual acuity assessment, fundus examination, slit lamp examination, intraocular pressure assessment, anterior chamber angle examination in cases with high intraocular pressure, and dilated fundus examination, as well as dilated fundus examination. The drawback of this system, it has many steps and difficult to follow as a screening program. Regarding the Egyptian status, concerning diabetic retinopathy screening, up till now, no national diabetic retinopathy screening program. Regarding today practice and the future, there are many advances into the retinal camera technology. The evolution has progressed from black and white to color photography, from film-based to digital photography, from narrow field to wide and ultra-wide field ranging. The drawback of the digital retinal imaging is its inability to identify and degrade macular edema accurately. This is a handheld portable fundus camera with Wi-Fi to be sent to ophthalmologists in areas with no sufficient number of ophthalmologists. There's also nowadays the mobile-based ophthalmic photography. This is an appearance of a fundus photograph through a non-mydriatic fundus camera. Sometimes it has some artifacts, especially in people with narrow pupil and media opacity, which is very quite common in diabetic patients. Non-mydriatic fundus cameras have good sensitivity and specificity all over the world. Teleophthalmology provides vision care for a distance using technology. India is the leading country in teleophthalmology. Artificial intelligence also helps, but up till now it is not practical in screening for diabetic retinopathy. E-health ophthalmology also. Home message I want to say, diabetic patient management should be in an orchestra-like approach. The diabetologist, the nephrologist, the neurologist, the vascular surgeon, the ophthalmologist, as well as others. Diabetic retinopathy should be raised as an important public health problem. A properly designed screening program and a suitable budget are mandatory. It is costly. Thank you for your attention and have a good night.
Thank you, Dr. Hatem, for illustrating and interesting lecture.
Okay.
تفضل.
دكتور حاتم المحاضرة جميلة جدا ورائعة بصراحة. الله يكرمك. بس أنا كنت عايز أسأل سؤال، حضرتك يعني اتكلمت باستفاضة وشغل جميل جدا في المحاضرة. الناس الدايابيتك اللي عندهم كاتر بتشتغلوا ازاي تشوف الريتنا؟ بالفلوسنت بقى.
Okay. Regarding diabetic patients with media opacity, we have two issues: the anatomical diagnosis and the functional diagnosis. If the media opacity is very dense, we use the ophthalmic ultrasonography to assess the posterior segment status. This is very important. In some cases of cataract, media opacity is not dense enough. We can utilize the optical coherence tomography. We can utilize also the fluorescein angiography. Regarding the functional diagnosis, the patient is subjected to an operation. He wants to see. He wants a vision. He wants a result. We utilize the electrophysiology, electroretinography, electroculography, and visually evoked response to assess if there is a suitable chance to have a good vision after the intervention or not. The problem of electrophysiology, it has a high rate of false positive and false negative results. In some cases, we do the surgery and tell our patient that it is a chance surgery. Whatever we did in the investigation, sometimes surprises occur. We can do some surgeries everything is appearing to be normal, the surgery is technically very nice, the vision is not good. On the contrary, in some cases, the investigations tell me that he has poor visual prognosis, and after the surgery has moderate or relatively good prognosis. This is the problem of electrophysiology. This is how we prepare diabetic patients for intervention in cases of cataract. العفو يا فندم، شكرا.
Thank you.
What? Lamellar macular hole. Cases of macular hole are according to the visual acuity. The visual acuity is a very important prognostic factor. If you had a suitable or reasonable visual acuity, vitreoretinal surgery will give good results. In the vitreoretinal surgery, we have a problem in that there is in many cases there is a disparity between the anatomical and the functional result. In some cases, the anatomical result is marvelous. Despite this, the patient is disappointed because the functional result is not good. The initial element in ophthalmology is to assess the visual acuity. If he has very poor visual acuity, most probably the surgery will not give satisfactory result. If there is an initial or baseline satisfactory visual acuity, intervention would give a satisfactory result for the patient. The only treatment is vitreoretinal surgery, or what we call parsiplana vitrectomy. They remove any traction on the macular hole, whatever its stage, or lamellar or full thickness. Only vitrectomy. With its different techniques, but the only treatment is vitrectomy, parsiplana vitrectomy.